Hey John, next episode, sacroiliac dysfunction.
So fun. So fun when you have it, you know?
It is a fun joint to work on, I think.
Have you ever had SI joint pain?
Indeed I have.
Yeah.
Yeah, actually we talked about the elevator shaft fall.
Yep.
And I fractured part of my innominate and I developed left-sided SI joint issues for a while.
Gotcha.
Yeah.
What is the innominate?
It's one half of the pelvis, basically.
Gotcha.
If you picture like a heart-shaped bone and cut it in half, one half is the innominate.
That makes sense?
Mm-hmm.
There you go.
There you go.
Yeah, I've always had problems with my right side of my SI joint. But if you look at like my right hamstring, super tight. Left side, not so much.
Yep.
So I would assume that would have some sort of unbalanced pulling on the pelvis, and then as a result the sacrum, and there you go.
Yeah, that's exactly how I see it. Something is imbalanced.
Yep.
So it's either, well, with guys, well, I don't want to generalize too much. It tends to be a stiffness that's asymmetrical, and when someone who's hypermobile, that could be guys or girls, there's more of an instability issue, and maybe like a glute medius, for example, is too weak on one side. And sometimes you get a combination. If you get a stiff hamstring on one side, a weak glute on the other side, you get even more shear at the SI joint.
Yep. And I think from my personal experience, and this could be totally wrong based on a clinical perspective, SI joint pain is one of the leading causes of lower back pain. Obviously not the cause, but the end result of the dysfunction going on. Is that what you see mostly, or do you see some other things happening that are the leaders of the back pain?
So that's kind of a hot topic. There are therapists that will tell you that there is no such thing as SI joint pain because the sacrum and there's not a lot of movement there. We're talking millimeters of movement. Some would even say it doesn't move at all. Mm-hmm. I do think it's a thing. I've had it, and when I sort of correct it in people, they get better. So I don't know if the underlying mechanism, like with the pain producing aspect, is necessarily the SI joint. I think it is, but there could be other things too, like the ligaments. That's kind of where my brain is at. Are you stressing the ligaments that keep the pelvis together?
Absolutely. One of the things I find kind of interesting, and this is my experience with the SI joint pain personally, is you can almost feel the line between the pelvis and the sacrum. And that's what people describe. They're like, yeah, I feel like this like line, it's like a pinching thing, like right down. They literally draw the line of the sacrum in the pelvis. And I'm like, well, okay, I think I know exactly what that is then. Yeah,
there's a sign called the Fortin's finger sign. I don't know, Mr. Fortin or Dr. Fortin, I guess, describe this, but they'll take their thumb and they'll point right to the spot. And when it's like that localized, usually, not always, but usually that's an SI joint dysfunction of some sort.
Yeah.
Yeah, but there's other sets of symptoms that go along with it typically. Sometimes you get groin pain with it. It can get to the point where it starts to radiate down the leg and, get basically sciatica type symptoms.
Yeah. Now, just so that we can cancel out some other things, what are some other sources of low back pain? Then we'll come back to SI joint. What are some other like common lower back pain things that aren't SI joint?
Well, there's lots of them. Okay, so there's disc pathology. Typically, that's going to be bending forward at the waist is going to produce pain, and usually give you pain and numbness down the leg. That can overlap. There's so much overlap with the back, so it's very nuanced. But okay, I'm still going into generalities. Then there's things like stenosis or joint type pain of the spine. That's usually extension kind of bothers your back. So leaning back, gives you signals down the leg. That's more like a stenosis typically. There's a lot of mechanical stuff. So you could just have tight muscles on one side. QL tends to be a big one. A lot of golfers that their fall through is a shortened position of the QL. And that thing gets fired up really easy and tender just about all of my patients. So that's just the tip of the iceberg.
Right.
There's piriformis syndrome. There's like lots of different types of impingements we can get into, which tend to be more hip related, but they all, hip and back kind of go together, just like shoulder and neck kind of go together.
Yes, absolutely.
And people always like, I don't know if it's my hip or my back. And it's, well, it doesn't really matter. It's kind of both.
And one of the things I see so often, just going back to the SI joint, so I think all these things deserve probably their own podcast in general. They're so important. But when I look at lower back pain, and obviously it's super common for so many people, especially in the lives we live now. Like, look at us, we're sitting in these chairs. Everybody's getting lower cross syndrome. Everybody's getting excessive anterior tilt, and as a result, we're seeing a lot of lower back issues.
Absolutely, especially with pandemic, people are sitting more.
Yep.
People in front of Zoom more. I'm seeing more of that same pattern. So why don't you go ahead and describe lower cross syndrome so that our listeners know what we're talking about.
So lower cross syndrome, if we look at the pelvis, and this is actually super easy just as a layperson to see. Obviously, when you're guys like us, like we can just see it immediately. But if you just sort of tune your eye to somebody's pelvis or your own, looking in the mirror, if you have a tilt forward of your pelvis where your low back is kind of arched, your front of your spine's kind of sagging a little bit, that's typically lower cross, and especially if you have low back pain, you kind of deduce that as well. Typically, it's a result of tight hip flexors, weak hip extensors. Oh God, he's getting a phone call. Super important guy. Weak trunk and pelvic flexors, so the core muscles, typically like rectus abdominis, those oblique muscles too. And that's usually the cause of the lower cross syndrome. Then usually tightness down those erectors of that lower spine.
Yeah. One of the ideas is if you're tight one side, it's going to inhibit the other side.
Yep.
Yeah. Again, it's like a very general model. It's a good way to it's like a template to see someone's body, but you can't just be like, oh, that's lower cross, just stretch the hip flexors. Like that alone is not going to solve it. You have to look at everything, really.
Right.
But yeah, that's a good sort of template to view it through.
Yeah. And one of the things I've found is, because I have a lot of patients, I have a lot of clients as a personal trainer that have lower back pain, and it turns out when I do a ton of core training with them, it tends to go away.
Yeah.
And they're like, yeah, I haven't seen my chiropractor in weeks because I haven't had a problem with the lower back. Yeah. Is that something you've experienced too? Like, hey, if I get this person training their core, lower back seems to
I mean, basically everybody gets core training in physical therapy.
Yeah.
It's the center of your body. So we have this expression, it's proximal stability for distal mobility. So if you have to have a stable center to move your limbs on. If the center is not stable, you just, you're kind of a loose mess. So, and then you create shear stresses at joints like the vertebrae, like the SI joint. So yeah, core stability is sort of physical therapy 101.
And speaking of the shear stress, if we look at the sacrum and the pelvis and the way they operate on each other in that SI joint, we have this thing called nutation and counter nutation, which you and I were just trying to figure out 2 seconds ago. But pretty much when you are in that anterior tilt, one thing that is happening, even though there's, like you said, millimeters of movement between these two joints, any sort of movement is going to be kind of uncomfortable and painful. When you go into that counter nutation, which is the pelvis rotating forward and the sacrum rotating backwards, that movement it does not like. It's like, unlocking a door, except a door that does not want to be unlocked. What you want to do is you want to find the hips extended, the core pulling up too, and those hip flexors loosening so you can pull back that pelvis. That way that sacrum can get set in its place, which is called nutation, which is what we want.
Yeah. I like to think of the sacrum as like a wedge that's driven between the two heart-shaped bones. And that's sort of the lock that keeps everything together.
Yeah.
Yeah.
That's a great way to picture it, because it's just such a, you really want to lock the thing in place.
There we go. You got it. So one of the things I'm interested in too is like what causes it in the first place.
Yeah.
I've seen a lot of clinical patterns. And it's usually like a chicken or the egg type of situation. Like, you're almost always going to get a piriformis tight on one side or irritated on one side. Is the piriformis pulling something out of position, or is the piriformis reacting and trying to glue you together, which I kind of think it's more that. Mm-hmm. But at the end of the day, it's all about really balancing the equation, right? So if you look at both hamstrings, one's missing 20 degrees compared to the other, you gotta fix that hamstring.
Right.
Or same thing with hip flexor. Basically, any muscle that attaches to it, you gotta look at any imbalances and do your best to correct it.
Yeah, that's one of the things too. When you have that anterior tilt and that lower cross, well, those connection points for the hamstrings are getting pulled up even higher. So those hamstrings are desperately trying to hold on to some sort of stability at that spot. They're getting pulled taut, and as a result, you get a lot of people with hamstring tightness. And I've actually found too, with myself personally, also my clients, if I can get them into more neutrality, they can squat deeper, not by the fact that I've mobilized their hamstrings at all, just because I've put their hamstrings in a better position, created some slack in that area, and now they can squat deeper.
Right. And then there's the hip, like the joint arthrochomatics to think about too, because if you go into neutral, now you've opened up the joint space for the hip.
Yep.
In certain positions, you can, I'm crazy about hip impingement.
Yes.
You can create impingement in the front of the hip, depending on the way the ball and socket joint's working. And I do think, and I see this a lot, where you get a hip impingement and that turns into SI joint pain. So one of the things that happens...
Interesting to think about.
Yeah, so one of the classic things to see with hip impingement is loss of hip flexion and loss of hip internal rotation. When you have loss somewhere, it's going to go elsewhere. Your body's going to find the motion elsewhere. That's just how the body works in general. So if stiff one joint, the neighboring joint's going to be loose. And that's what we see with SI joint and like hip impingement. You lose hip flexion and internal rotation, you go into a squat, something has to pick up the slack, and you get more shear at the SI joint. So I see that really often with hip impingement.
That makes sense. Now you've been doing a lot of work with hip impingement. Do you think that solving some of these SI joint problems also, as a result, solves some of that hip impingement problem as well? Like, okay, if I get some more hip extension ability, strengthen my core, so now I'm finding a neutral pelvis, and I'm loosening up my hip flexors, and I'm loosening up that lower spine. Am I getting any sort of benefit there? Are there other things that are going to cause that hip impingement as a result?
Right. So there's symptom and dysfunction. Right. So we usually try to resolve some symptoms first, make the patient feel better. But then at the end of the day, you have to figure out what the underlying mechanism is. So, with this example, it's restore the hip flexion and internal rotation. The SI joint shear goes away. And then, of course, strengthen anything that's weak and stabilize core. Absolutely.
Yeah. One thing I've found, too, and if you watch any of the videos on our Instagram, any of the videos we've taken, especially the longer form stuff, we have, Noah demonstrating exercise, and I'm talking him through it. I'm so crazy about having a neutral pelvis in everything you do, because I have so many people who are either scared to do certain exercises or whatever the case might be because they've done it in the past, they had lower back pain, and all I do is get them into a neutral pelvis, and all of a sudden like, oh yeah, now my core's working and I don't really feel that lower back anymore. Is that something you found too, just like finding a neutral pelvis seems to alleviate a lot of that?
I think it's a great starting point.
Yeah.
But I do think, what I don't want my patients to think is like, you have to walk around with like a perfectly neutral core at all times, and when you sit, it has to be perfect. And, it's a little bit unrealistic. I mean, the spine and the hips and everything are meant to move, but can you control it? So it's really about developing motor control and eliminating any kind of compensation patterns.
Yeah, absolutely.
Yeah, and so what you mentioned, that's a great starting point, and then build from there. Teach them some more complicated patterns, maybe getting the spine flexed and extended, but controlling it.
Yeah, that's probably something I don't do enough, is utilizing spinal flexion and extension to start incorporating some of these things. Because I'm always like working with just a neutral spine, flex at the hips, extend at the hips, and I'm not really doing enough of that, and that's probably really important. I mean, I do a lot of rotation, which we should talk about when we talk about lower back pain too, but yeah, I don't do a lot of flexion and extension stuff.
Well, that's a lot of the CrossFit ideas, like those kipping pull-ups are like a perfect example of like getting sort of global flexion extension of the spine.
Yeah.
Which, you can make the argument that's building resiliency as long as you're not sensitive in those positions. So usually, I don't see people in that realm, that's because they're coming to me because they have sensitivities. So usually if they're extension intolerant, I'm going to try to fix that and then maybe build some resiliency and do something like, or, if they had flexion intolerance, eventually get into doing like a Jefferson curl, which I know is very controversial exercise, but
what's a Jefferson curl?
That is so picture like picking up something from the ground like the worst way possible, like rounding at the back.
Okay, gotcha.
Right.
Oh, okay, I've seen that. And then they kind of like round on the whole way up.
Yeah. Exactly. Right. So if you had like a very fresh herniated disc, I would never do that.
Oh, we don't do that.
But you do want like the body to get adapted to certain positions without blowing a disc.
Yep.
So it's not my first thing I go to, but it's something I aim for down the road.
And one of the things I found too, we talked about anterior tilt, lower cross, and that tilt of the pelvis forward and back being a key indicator of, key solution to solving some of that SI joint discomfort. I know that's the main crux of our conversation. But one of the things I've found too, because you have these anterior and posterior oblique slings, I've written a lot about them on the Motus blog, so you can go check that out, is working on rotation so you can get these global sling systems stabilized as well, functioning well, coordinated well, and that also seems to solve a lot of the lower back pain that my clients experience as well. Have you had that experience too with utilizing rotation in training?
Yeah, I love using rotation just about everything. So I usually will start off with sort of isolated like cardinal plane movements and then incorporate coplanar stuff, and that's basically exactly what you're talking about. Yeah, I think usually when my patients are getting to that point where they can do the coplanar stuff without pain, they're probably ready to do it on their own and be discharged basically.
Yeah. Now, what are some of the things that, let's say you've deduced, okay, it's not stenosis, it's not XYZ, this is SI joint dysfunction. It's something I think I can treat. What's your initial progression pathway? Where do you start, and then where does it go from there?
Well, it's going to be totally based off of what I see in the evaluation. So I'm going to correct whatever weakness or imbalance there is. But the very first thing I do is I put a stick between their knees, and I have them do like a little push-pull thing. It's called a muscle energy technique, and sort of resets the pelvis. And I teach them how to do that on their own. It's something they can very quickly do in a few minutes. So I'll start with that. So basically empower them to say, hey, when you're having that pain you can point to at the SI joint, try this. I've got YouTube videos of it. We can put the link in there.
Yeah.
Just to get you out of pain. But the fix is whatever the underlying cause is.
Mm-hmm.
So for example, use probably one hamstring's tighter.
Yeah.
Right. And you gotta look at everything that attaches to the pelvis. So QL can do it. Hip flexor can do it. Glute medius, TFL, adductors, anything that attaches to the pelvis can basically cause an SI dysfunction. So that's where the evaluation comes in. You just have to treat whatever you see.
Yeah. And are there any sort of general things you see on a broader basis? You're like, okay, well, I'm getting a lot of SI dysfunction coming into me, and sure, like, it's not always this, but 8 out of 10 times it's this thing. Is there anything that you're seeing from that perspective that you could throw a generality out there and say?
Yeah, I mean, the hamstring is a common one. Hip flexor is a common one. And I'd say glute medius weakness would probably be the number one.
Interesting.
Yeah.
You'd say glute medius weakness.
Weakness, yeah.
Now, why would you say glute med over like glute max?
Because if you look at what the glute medius does, so it does hip abduction, so like a sideline leg lift.
Yep.
But in standing, it has a different function. So it basically keeps your pelvis parallel to the ground
right.
when you take a step. And if you get weak glute medius, you get what we call a Trendelenburg sign, where someone's hip kind of dips down.
Yeah.
Well, if you think about what's happening to the pelvis, you're getting sheared right at the SI joint with every step you take. How many, we tell people to take 10,000 steps, that's 10,000 shears a day.
Yeah. That makes perfect sense.
Yeah. And by the way, I see that as a big time contributor to hip bursitis. Because if you think of the pelvis sort of dipping down with every step, now you're pushing your pelvis sort of laterally into the bursa, into what's behind the bursa, which is that thick, leathery IT band. You're getting chronic compression of the bursa, and that thing flares up on you.
Mm-hmm. There's actually a woman at the gym who's dealing with some bursitis in the lateral hip. She's a kickboxing instructor, and she's just kicking all day, but she doesn't do a lot of strengthening as a result.
Mm-hmm.
And so she's just getting, that whole area just getting lit up.
Yeah.
And I was like, all you gotta do is strengthen your hips a little bit, and I'll show you some stuff. But
yeah, I'd be looking at glute medius first.
Yes.
And then I'd look at how she moves. A lot of times it's common to use your QL instead of your glute medius because they have very similar functions. One basically lifts the pelvis from down to neutral, and the other lifts the pelvis from neutral to up.
So that hip hike sort of situation.
Hip hike is QL basically. So you can easily substitute QL for glute medius, and that's a super common pattern.
Yeah.
And by the way, that is, I see that all the time where you get weak glute medius, QL compensation. Patients a lot of pain because the QL, when you're standing, the QL's on. So you're just feeling back pain with a tight QL. They go get an image, and image, sure enough, finds something, because that's what imaging does. They find, oh, you got stenosis here, you got a bulge just here, blah, blah, blah. And the patient kind of freaks out a little bit, doesn't want to bend over anymore. Yeah. Maybe they get surgery to fix a disc, and then nothing changes because at the beginning all it was a little compensation pattern and a stiff restricted QL.
Yeah.
Super common.
Now, when we're talking about the glute med and some weakness there, I think it's super common. You see it all the time, especially when you have an athlete, a client who comes to you and they're capable enough to like do some single leg work and do some dumbbell single leg work, something more challenging like a single leg RDL or single leg squat, and you see that hip drop. What is your first go-to exercise to strengthen that glute medius?
Well, the first thing I do is cue them. Can you hold this? Is this just a motor patterning thing? Is this just an inability, like a lack of skill, basically?
Right.
So first cue them. If they can't fix it there, then I'm going to do some form of glute medius activation. Probably the most basic thing I'll do is have them stand on a step, like with their 1 foot off and 1 foot on the step, and their feet sort of parallel, and then the foot that's sort of hanging in the air, I'll have them drop it down about 1 inch and then hike it back up so that the feet become parallel again. And just, and I'm tapping their glute medius. This is the muscle you want to use, it gives them tactile cueing.
Yeah.
Put them in front of a mirror so they can see it. It's a very hard one for people to understand, But once they get like, oh, that's how you use that muscle.
Right.
And that'll progress to like hip abduction. You know, I do a lot of side lying hip abduction, which gets a little boring. So then I try to do things like zombie walks. Ever seen that one?
Yep.
I'll put a link in the description about that one too. That's a great one. Even just at the gym, the seated hip abduction, I'll use that. Anything to strengthen glute medius.
Yeah. Yeah, I definitely like, you know, mini band, side steps, lateral steps, whatever you want to call them. In all sorts of positions too, like standing straight up. I'll do one where I could have them, they'll be completely erect, and then I'll have them down in sort of a bed position, so you get a little bit extra rotation in there too.
The side steps is a great example of compensation, right? So you can, there's a great exercise for glute medius if done right. So if you picture yourself in a semi-squat position, band around the knees, sidestepping, keeping core or torso straight and down, that's how it's done right. But you could easily get sort of a teetering mechanism.
And it's the most common thing I see.
Right, and guess what that's using? That's using QL.
That's using that QL.
Right, so you have to be really tight with your Qing.
Yeah, and that's one of those things I see all the time, and I just get people right in front of the mirror. I'm like, do you see how much you're bobbing side to side? Let's try to correct that.
You'll see it a lot in side-lying hip abduction, so leg lift. And I was just watching this today in the gym. So most people will kick that leg as high as they can. It's all about that range of motion, right? Well, okay, so if you're on your side and you lift your leg up laterally, right, you only want to go as high as you can without the pelvis tipping up towards your back or hip hiking. As soon as your pelvis starts to tip up, now you're using QL. So when you're going for all that range of motion, really just firing up that QL. Maybe you're getting some glute medius in there, I don't know, but people usually just like rifle through that exercise, do as fast and as far as they can, and you're just going to irritate your back.
Well, a lot of times too is they rotate the toe up, and then they end up just using their TFL for the whole thing too, or their hip flexors.
It's a whole other conversation, and TFL then attaches the IT band, and like, I don't know why, down the side of my leg it really kills. Well, you're yanking on your IT band, because the IT band is tethered to your femur, so your TFL has the ability to kind of grab that leathery cord and pull the whole leg up.
Yep.
And it just shears the IT band on the quad and even on the bone, and it irritates the crap out of it.
And that's one of the things too, going back to that neutral pelvis conversation, I get a lot of people when they find themselves in anterior tilt, as they do like a side step, they'll get that, I'll be like, okay, where are you feeling this? And they'll point to like the front side of their hip, where that TFL is, versus like, you know, the glute med area, which is where I want it to be. I'm like, okay, we need to make a correction probably at the pelvis so that we actually get the areas that we want to working right.
Yeah, and then that always boils down to core stability, right?
Yeah, always.
Yep, because core stability is neutral pelvis basically.
Yeah, and it's always amazing to me how many people don't do any core training or just do crunches.
Yeah.
I'm like, ha.
Yeah. Well, that's why therapists use things like dead bugs all the time, because it's like neutral pelvis, move your limbs, learn to use your limbs while being in neutral.
Yep. Yeah, that's one of the things I find too, is everybody wants to do that dying bug. They extend their leg out. It's the first thing to go. That low back starts arching.
Oh, you get the arch, exactly. Yep.
And like, oh, why am I feeling this in my low back? I'm like, I don't know. It's a mystery.
Yeah, it's a very basic exercise, but it's a good way to assess a patient and also teach them how to maintain neutral core. And it's really easy to regress or progress from there.
Yep. And I'll be honest, I really don't do much trunk flexion when it comes to my core training. You know, repeated trunk flexion. I do primarily bridging, so like your plank type positions. I do dead bugs, and then I do rotational work. Is there anything you do on top of that you're like, nah, you're missing this?
I mean, I do some flexion. I mean, it just depends on what I see in the evaluation.
Yeah.
Okay, so if they're extension intolerant, flexion is going to feel good. So sometimes I'll use it sort of therapeutically. But I also want them to understand how to flex on a neutral core as much as like extend on a neutral core. So yeah, I'm not afraid of flexion. I know there's articles out there like the military, stop doing crunches because it's going to herniate your disc, and that's bogus. I mean, if you can't do a curl or like a sit up, how are you supposed to get out of bed or get out of a chair? I mean, there's so much stuff out there these days that just terrifies people to move, and it's just harmful.
Yeah, the body wants to move in a whole bunch of different ways. You know, like I was doing handstands today. It's like you want to move your body in as many ways as possible and as often as possible. You don't want to fear anything. And you don't want to, in my opinion too, when it comes to things like lower back pains, you don't want to be like, oh, I can't squat, it hurts my lower back, I can't deadlift, it hurts my lower back. You want to find whatever the crux of the problem is, solve the problem so that no exercise is off limits. You can do crunches and it's not a problem. you can do a deadlift and it's no problem.
Yeah, there may be acute phases of pain where you have to modify or stay away from something, but then you eventually want to get back to doing it the correct way.
Yeah.
I mean, a lot of modern medicine wants to remove. I think that's the wrong way. It's modify and then get back to doing it right.
Yes.
So you want to add movement. I mean, all I have to do is look at my 2-year-old daughter, the amount of positions she gets into. She gets in these handstands. She goes into like a scorpion pose like all the time. She like basically does yoga.
Yeah.
You know, like all day.
Yeah.
Yeah. And I mean, what happens is as kids we move in all these different ways, and then as we become adults, we go to work and we don't go into these weird postures, and and we lose the ability to do it.
Yeah.
So
now, do you have any self-tests for people that they could do for them to listen to this podcast? Be like, well, that kind of sounds like what I'm going through, but they also said that there could be a whole bunch of other things. Let me make sure it's this thing that they're talking about. Is there any things that people can use to deduce? Okay, this is SI joint pain versus
SI joint pain is almost always a pain you can point to at the area where the sacrum and pelvis meet. So that to me is like the number one. Someone's like, it hurts right there in that spot. I'm like, most likely that's SI joint pain. And then I'll usually do a supine to sit test. So I'll have them lay on their back and then sit up and look at their ankles and see if there's one different from the other, like lengthwise. That's usually an indicator because you'll get what's called a functional leg length discrepancy if one innominate moved anteriorly or posteriorly. It gives the sort of false appearance of a leg length discrepancy.
Gotcha.
But you kind of have to be able to look at your ankles before and after you sit. So some people have a true leg length discrepancy, like one femur is actually longer than the other, and if that's the case, when they're laying down, the discrepancy will be the same as when they sit up.
Right.
But if they have a sort of what we call a functional leg length discrepancy, which has to do with SI joint, something will change. It'll go from the ankles line up, and they sit up, and then suddenly one shifts forward or shifts back. And that's sort of a pretty clear indicator of SI joint dysfunction.
That's an interesting one. I didn't think to consider that because obviously we talked about all the possible causes and then what ends up happening in the pelvis, that shift. Yeah, it would make sense that one leg would appear longer than the other.
Yeah. If you gotta look at some, it gets really crazy. I don't want to get into the weeds on this because it took me hours of one class just to figure this out. But basically, if your symptomatic side, if that leg goes shorter when you sit up, that innominate is anterior. If it goes longer when you sit up, then it's posterior.
Gotcha.
And then you have to activate the opposite side to kind of reset everything.
Now you did an eval recently with a person who had some lower back pain, but you were significantly more concerned about her issue than maybe I would have probably came to the conclusion of as a personal trainer.
Yes.
What happened there and why did you make the conclusion that you made?
Yeah, so what she was describing to me in the subjective part of the evaluation sounded very much like SI joint pain, which is like pain that you can point to, pain with sitting in a car, pain with like unilateral stuff like a lunge, and so I was like, oh, this is definitely SI. But then I started to evaluate her, and then I found she had some neural tension, which means like we use what's called a slump test. You sit in a slump position and kick your leg out. If there's pain in your back or shooting down your leg, that's a positive test for something impinging on the nerve, which, by the way, can go along with SI joint, so I wasn't alarmed yet.
Right.
Then I had her do a stork test, which is staying on one leg, put your hands on your hips, and you lean back to extension, and she had significant pain on one side, and she almost wanted to like fall when she did that. So that's a sign of potentially a spondylolisthesis, which is too much movement of a vertebrae. It could even be a fracture of a vertebrae. So that, that could be stable or unstable. That's a refer out immediately kind of scenario.
Now, was the pain still in that SI joint area? Because I can imagine in the days that I've had SI joint pain, I would go into extension like that, probably feel pretty uncomfortable.
Yeah, I was looking at the quality of pain. It was a lot of pain. She's young, like that type of pain shouldn't be there at that age.
Right.
The fact there was some neural involvement, which, by the way, does not rule out SI joint yet until the next test. And just like, her age, she's probably very mobile in her spine at her age. And with a lot of mobility, you can get sort of that spondylolisthesis happening and get to the point where it's pressing on a lot of neural structures and be kind of damaging. So then I had her on the table, and then I did like a straight leg raise, and she had pain with about 20 degrees range of motion. And then I repeated the test with her knee bent. So straight leg raise, it could be disc, it could be a tumor, it could be neural tension. So when you take the knee extension part out by bending the knee, and she still has pain, that's a sign called sign of the buttock. That means there could be a lesion somewhere that's pressing on a nerve. Now, a lesion could mean like a tumor.
Yeah.
So there was so many red flags there, and I didn't 100% know. Like, do not pass go. You need to see an MD, get an image, and find out what's going on.
And this is a good moment, I think, for a lot of people who are either personal trainers or getting their physical therapy degree or getting their exercise science degree, where, I might have looked at that and just been like, okay, it's SI joint dysfunction. Let's do some core training. Let's do some glute bridges, and we're going to solve this problem. And you always need to consider the fact that the human body is very complex. We know nothing. And if you're unsure, refer out. Try to find somebody who knows more than you. If you're a personal trainer, go to a physical therapist. If you're a physical therapist, go up the ladder again, because a lot of the times we try to oversimplify things. Oh, people just have weak glutes, they have tight hip flexors, they have a weak core, weak shoulder retractors, so on and so forth. We oversimplify all these problems when they can get pretty complex, and if we do the wrong things with that sort of person, we could cause significant damage.
Right. I'd rather just play it safe, right? I mean,
yeah.
It's very possible she just has a very reactive SI joint, and I hope that's her case.
Right.
But I want to know so I can proceed and feeling confident that I'm not going to do any damage, or I'm not going to miss something like cancer.
Yep.
So do everything in the right order. Don't skip steps, and don't be afraid to send somebody out just because you want to make them feel better. It's not so dire. You got to do it the right way. That's the bottom line.
Yeah, I actually had this is off the topic of SI joint pain, but there was this kid that came to me. He's like a bodybuilder, and he was having some knee pain, and he was having some knee pain during a squat, and I was like, okay, I'm having an idea of what it is, sort of off the bat, because not a lot of bodybuilders are training their glutes very hard. Not a lot of, bodybuilders are training their glute meats very hard. They're just doing, their presses, their pulls, their deadlifts, their squats, so on and so forth. They're not doing a lot of lateral work. So I'm going to make an assumption here. And so I saw him move, and I had him do some balance tests. But one of the things is he was bow-legged. And early on in his life, he had a surgery to sort of correct the bow-leggedness. And that was one of those things where it's like, okay, I sort of deduced that he did have some lateral glute weakness, but there's so much stuff going on at the knee that I can't just say that it's that. I can try to treat that and see if that's the cause, but he's also has this thing that he had surgery for, and he has pins in his legs, and he still has bow legs. He still has bow-legged tibias, and these are things that I'm always thinking about. It's like, okay, well, there's probably something else going on here that needs to be a larger conversation. If it's not that, great, but it could be, so let's have another conversation with somebody who knows more than I do.
Yeah, and we'd have to rule out meniscus, ligament tears, all those other things too, muscle tears. And sometimes, if you can correct the position, and then the pain goes away, it's probably a good sign.
Yeah.
But best to do like a thorough evaluation.
Right. Do you have anything else on the topic of the SI joint? I think we were pretty thorough on it.
I could talk for hours about SI. Yeah, but I think that's good. I think we should wrap it up there. Maybe we should next do a whole thing on just low back pain, without SI joint.
Yeah, I think so too, because I treat so much low back pain as a personal trainer because it's such a common ailment people have. I'm not really thinking about the other variables as much as I think about SI joint, which is not right. I should be thinking about those other variables.
Agreed.
Yeah.
All right, let's end it on that. John, as always, great conversation.
Yep.
And we'll see you next week.
Next week. Yep.